Okay. Good, Koto. We're going to begin with our snapshot audit session 3. What is being measured? I'll begin with the karakia. Tu tawa mai I runga, tu tawa mai I raro, tu tawa mai I roto, tu tawa mai I waho. Kia toai te moritu, te moriora, ki te katoa, homie, huie, taikie. So, hello everybody. Session 3 about measurement. So this is session 3 of 5. And what we're going to talk about today is just what is being measured in the snapshot audit, the process measures, the measures for IPV and CAN. A little bit, I'll talk about ethnicity, why we're collecting data around ethnicity, and a bit about just the difference between an active and a passive referral. So this is just a small session to give you some more information so that you have a better understanding of some of the decisions and why the snapshot audit has been developed as it has and the decisions that have been made along the way. The next session, just so you know, session 4 about entering the data is the same thing that's offered twice, either on Monday or on Wednesday. So there is absolutely no need to attend both other than for Kathy Lowe, who will be leading the session. So just to orient us that we're still in the planning stage. So last session, I talked about approaching the snapshot audits as a PDSA, Plan, Do, Study, Act cycle. And we're clearly still in the planning phase. So we don't start the doing of collecting data actually until July. So we're still planning. So we're here to support you as you go forward in the plan. So I'm going to put us in breakout rooms just because we know there are not enough opportunities for the coordinators to get to know one another. So while we join on a Zoom session, I think it's important that we take that opportunity to get to know one another a bit better and learn from one another. And I just have this quote here. So I thought if maybe you could introduce yourselves to one another and maybe comment on today's session about measurement, what this quote means to you and where you fall in interpreting this quote. So it will take a couple minutes for me to have the breakout rooms, and I will pause the recording now for a minute. Hello, everybody. Great to have you back. Are there any insights that anybody would like to share from your groups? No, and Kathy, if you'll just be able to check in the chat for me, should people use the chat during today's session, that would be great. Thanks.
I think, Jane, in my little group, I was the only one who'd ever done a VIP snapshot audit before. So I think there's that sort of overwhelming cloud of, I still don't know what this is about in my group.
Yeah, sounds good. Very good. Any other comments?
I think from our group, then I have done it before and I see absolute value because you can use it as a benchmark to increase and for your you know, almost like this PDSA, you know, to increase the questioning. But we were just talking in our group about there's a general lower compliance rate after COVID, so so it'll be interesting this year. So we in this preparation phase is really to remind staff that already now we're going to audit them from April, May, and June. Yeah.
Very good. Thanks for that. So moving on, what variables are included in the audit? So what does the snapshot actually collect? And I think we mentioned last time about balancing the burden of actually doing clinical audits with the benefit. So the more people we would audit, the more records we would review, the higher the precision of our estimates. However, the increase in work that's demanded to conduct clinical audits. So it really is trying to balance that precision of the audits with the benefit. So we also take that into account when we think, what will we measure? So we do try to keep it as essentially, I would call it a minimum data set. So the snapshot audit is meant to be just a snapshot. So it doesn't get into the depth of the clinical responsiveness to family violence. It only captures a select minimum number of variables. So some of the variables that you will be asked to enter are more just about which clinical audit are you entering, who are you, and let us know when you're done with the audit. So what some of the variables that we collect include, what district are you from? And apologies that we haven't put the resource into updating the names of the DHBs. So they're still listed as DHBs. And in some cases, there's more than one hospital choice. So if in your district, the snapshot audits have predominantly been based and conducted at the main hospital site, there are a couple instances where settings have elected to take independent audits at maybe two of their hospitals. So for example, Southern has two very distinct hospitals. Northland has several. So it is an opportunity in the snapshot system. You can take audits from both, or you can ask your IT person, data management team, to collect a random sample from across your main hospitals if you have more than one. For most districts, though, it will be their single main hospital that they will draw the sample from. So when you enter the data in the snapshot system, it'll ask, what district are you from? And it gives you an option to select a hospital. You'll then identify whether you're doing a CAN or an IPV audit, and which of the designated services you're doing. It'll ask you for the user. So what is your name? Who is it that is a user of the snapshot audit who is entering that data? It will then ask you for the number of admitted people. So this is what we talked about in session 2 around the number of eligible people. So this is eligible people between the period of April 1 through June 30th, through the 30th of June. So that 3-month quarter, that is the total number of eligible people women that were seen in the service during that time. From the number admitted, then you enter how many clinical records you're auditing. And again, we talked about this in session 2. It should be 25. You do have an opportunity to elect to do a random sample of more than 25 if you want more precision, perhaps in a certain one service. You may want to have better data. You may want to audit more than 25. If so, you should identify how many you're going to enter ahead of time, and you negotiate that with your IT department that you want a random sample of 35 instead of 25. So if you do audit a different number, you put there the number of patients, that's the number that you're actually auditing. In some cases, that will be less than 25. So if you're in a smaller district and perhaps your community mental health service, to be eligible, you have to be a new client in that service. And in that 3-month period, they potentially could have fewer than 25 new women clients. So the number of audited records, the number of eligible may be 19, and the number of audited may be 19 as well. Does that make sense? So for smaller districts, things like that can happen. You then indicate that in this case, that this is an official audit, which just means it is the national standardized audit from April through June, a random sample of charts. And once you've done entering the data, you'll have the opportunity to indicate that you're done for each of the clinical audits. It also will ask you whether you know the proportion of staff trained, and that is how many have received the core training in that service, indicating the proportion of doctors, nurses, midwives, and social workers that have been trained. And just so you know, this is often no, we don't know. And I think as we went around to the different sites last year, going over the Delphi tool and talking with Rachel and Rebecca, the documentation of and the knowledge of what proportion of staff has been trained is very difficult in most of your districts. There are rare districts that actually the participation in core training is documented digitally by perhaps the teaching and learning team or something. And service managers actually get a monthly tally on all of their staff and whether they have complied with core training, with all of the mandatory core training. So they do have that data accessible to them, but that's very few districts. So we know that most of you will be entering no to that. So the next set of variables that we collect are relevant to each of the selected records that you're reviewing. So I'll go over the variables that are collected in this minimum data set now. So for each person that has been selected and that you have the clinical record that you'll be reviewing, we ask for their ethnicity. For intimate partner violence, we ask whether the routine inquiry was done, whether there was a disclosure, and whether there was a referral. In child protection, we ask whether there was an assessment, whether a concern was identified, and if a concern was identified, was there consultation? So that's the basic minimum data set. In the ED, we do ask for the age of the person, their triage category, and whether they were admitted to ICU, coronary care, or the high dependency unit. And in child health inpatient, we ask for the age of the child. So those are all of the minimum data set that we collect for Snapshot audit.
Jane, can you tell us why in ED you're particularly interested in whether they were admitted to coronary care or ICU?
I think it would reflect whether they would probably be more severely unwell. So being able to assess IPV would probably not be possible.
Right.
So the ED record would not probably have a routine inquiry because there would have been prioritized care. So it probably goes along and measures the same thing as the triage category. Yeah, so that's why. Thanks, Kath. So in terms of ethnicity, the reason for collecting ethnicity is that generally in health is that it can inform funding, it can allow for targeted health services for Māori in particular and Pacific, and it can monitor the health system's performance. Te Aka Whaiora recently published a report on ethnicity data and an ethnicity data action plan that's really quite important in discussing the state of ethnicity data in health and calls for all of us to have a role. So they say Māori have the right to be counted. Being counted is an acknowledgement of being valued. So it is important for us as we collect service delivery with VIP to count the issue of ethnicity. So again, in the protocols that are available, there is a responsibility to have high quality ethnicity data, and that sits with all of us. The classification of ethnicity of an individual person that's called for in our health protocols is that it be a person's self-identified response to the question, which ethnic group do you belong to? And people need to be given the opportunity to mark all that applied to them. And not only that, but the protocol identifies that people should be re-asked this question every 3 years. So that is the standard that's expected for the collection of ethnicity. We know that historically, the protocols, people do not understand the protocols, and they have not been successfully applied in many instances. But as VIP, we feel that we are part of the health sector with the responsibility to collect ethnicity data. So we aim to do the best we can, given the limitations of the health system documentation of ethnicity. As you may or may not know, there's 4 different levels of ethnicity that's collected by Stats New Zealand and Health that can be collected in health as well. And the highest level is level 1, and that has the hierarchy levels of Asian, European, Māori, Middle Eastern, Latin American, African, Pacific people, and other. So that's at the level 1 of ethnicity. So in the snapshot data set, since we've started the snapshot, we've used the census question. However, we're not asking individuals. You are having to report what's in your health database around ethnicity. So we do realize the limitations, but if your DHB is collecting ethnicity appropriately, you can, in the snapshot center, tick on all that apply. So in talking with your IT data management intelligence people about your random sample, it may be that you could have a conversation with them about how are they able to report ethnicity to be included in the snapshot audit. So any questions about that or comments? The next issue is how we use the data. So we collect this data in the snapshot audit, and how do we use it? So for me, essentially, we use it with caution. It's critical that we realize the limitations of administrative ethnicity data. So our evaluation team includes Sarah Herbert currently, And Sarah will be leading the analysis of ethnicity, of the question of ethnicity, and particularly for Maudie. So we feel it is important. In the past, Denise Wilson has been responsible for the evaluation of ethnicity in our earlier snapshot reports, along with Nick Garrett and others that have supported them in that role. So the ethnicity will be led by Maudie, for Maudie, in terms of analyzing what it means. What we've done in the past, and we'll probably do this year again, is report Maudie versus non-Maudie, recognizing that it's a very blunt approach, but it gives us something to reflect on and to think about our system. We know that ethnicity data cannot tell us about unmet need or failure to respond. For example, when we've looked at data in the past, if there is a PACIA nurse who really doesn't think family violence is a health issue, so she would rather not have to deal with any disclosures, and she feels comfortable asking other people who look like her, expecting that family violence they would not be experiencing family violence. So that PACIA nurse preferentially has a bias to assessing routine inquiry among other PACIA, and probably does not do it very well. So she meets her target of not having many disclosures. And in contrast, it could be that there's a PACIA nurse that thinks that family violence is only a Maudie problem. So that PACIA nurse only assesses routine inquiry in Maudie clients and doesn't bother assessing for intimate partner violence in people who look like her. So I think you can tell when we have the information, there's different stories that can explain either over-serving, oversampling, over-assessing Maudie or under-assessing Maudie, and the quality that goes along with that. So there's multiple stories, and we don't have the depth of understanding from the snapshot audit what those explanations might be. So it's important for us to think about those things as we collect the data and we talk with services and we consider what does this mean. So we know that institutional racism is embedded within the system, and it doesn't allow for accurate and true experiences of violence within Fano to be known. So there are those multiple stories, and the data provides only one view. In our last report with Daikoti, she summarized that overall, the 2019 VIP snapshot findings show overall that both Maudie and non-Maudie are underserved with regard to routine inquiry. So our expectation that inquiring and talking about family violence becomes routine is not met for any populations of women. So overall, we know that there's a lot of variation in the quality and the consistency of both IPV and CAN across services and across locations as well. So generally, there is a concern of women being underserved. So that's just a brief review of how we've engaged with the ethnicity data and how over time we'll continue to look at it and continue to be challenged to understand and to make improvements based on what the data perhaps can tell us.
Jane, do you know if there's any information on the ethnicity of the person asking the questions in relation to the person, the ethnicity of the patient?
Yep, certainly not in Snapshot. I believe there has been some research done that explains some of the the stories, the two competing stories that I shared, those are both come from research in the past that's been done that I've read along the way. So there are some accounts and some qualitative research that talks about matching ethnicity from so there is some research that we did probably 15 years ago in South Auckland. There was an indication that women would prefer to be asked by the same ethnicity, people of the same ethnicity. I consider it's added value. So it doesn't release responsibility from talking about family violence with anybody, but certainly if someone is from their same ethnic group, there's added value that's provided in that service delivery. But I think the risk of bias is of concern for us, and being able to improve services to the greatest extent that we can to give the highest quality health service that we can. Any other questions? Okay. So moving on, after ethnicity, then we begin the question about being assessed, whether there is a case and what the intervention is. Briefly, again, the minimum data set. But this is a skip pattern, just so you understand. So if someone is assessed, then they go on to the next question of whether it's a case. And if it is a case, then they go on to ask what the intervention was. So in the case of IPV, if the documentation is that the person was not assessed, there was not routine inquiry, in the snapshot system, it will skip to the next patient. You save that and you will go to the next patient. So it's a natural skip pattern. And the same thing for child abuse and neglect. If a child protection checklist was not used, then you won't be asked about whether there was a concern and if there was consultation. So that's a natural skip process that happens in the data. So for child protection, was an assessment done? The options in the snapshot are no or yes. So that's just what you have to answer and enter in the system is no or yes. So this is children under 2 in the emergency department, A. So a no is that there's no evidence of a checklist or a flow chart or equivalent in the notes. So we give lots of room there. So some systems, over different periods of time, they actually didn't use a checklist. They actually had a much more thorough assessment that was done. So if they did that, that would be ticked, obviously, as an assessment being done. So whether in your district, in the emergency department, your protocol is a checklist, a flow chart, or an equivalent, it's whether that's completed. Now, if it's only partially completed, that would be a no as well, unless a concern was identified. So if there was, let's say, not all the questions were answered in the checklist, but there was a concern, then you need to tick yes to be able to go on to the next item, which is, was a concern identified? So that pathway into concern is takes precedence.
Jane,
So
I think in some districts they choose to do the child protection checklist for all children, not just for under 2s.
yeah.
Is that going to matter?
No, because the only thing that should be sampled are eligible cases, which is a random sample of children in the emergency department under 2. And not just children with injuries, but children in the ED for any reason. So historically, some districts only did a checklist if someone came in the emergency department for an injury. So this is the idea that because of the vulnerability of under twos, that should be the group that we focus on, certainly for this snapshot audit. So yes, is evidence of a child protection assessment, and it should ideally include a legible signature, and it should be complete. But again, if a concern is identified, then you would say yes, because then it moves on to the next query. So the next question is, was a concern identified? So this is either no, so no child protection concerns or risk factors were documented, or again, incomplete documentation, or yes, is that there was one or more risk factors identified. So in the child protection checklist, if anything is ticked there, then that would be a concern is yes. If there was a report of concern, for suspected child maltreatment or child protection concern identified in the notes, then that would be a yes as well. And then for those who have a concern, the question is, were the concerns discussed? Was there consultation? And that would be in all of your policies, I'm sure, is that if there is a concern that there be consultation, and it's different depending on what level of emergency department you have and how the ED consultants and the pediatricians and the child protection team may provide cover 24/7 for child protection concerns. But the idea is that if a concern is identified, that there is a consultation. So no would be that there's no indication of discussion about child protection risk factors and assessment. Maybe there's some plan, but it's unclear, misleading plan, but there's no indication of who the case was discussed with. A yes would mean that there's consultation occurred with somebody, and ideally it should be their name and their designation. And there should be in the notes discussion of the risk factors, assessment of level risk, and a plan. But minimally, we're looking for, is there evidence of consultation? And this is what it looks like in the snapshot system. So this case, was there a thorough risk assessment? That's yes. Was a concern identified? That's a yes. And was there evidence of consultation? That was a no. So that's how the data gets entered. So for each client, you have ethnicity. Ethnicity will be entered on the left. And then this is how the child protection, it's really just 3 data points that are entered with regard to child protection. So it really is just a minimum data set. So people do want to get more into the more detail of who was involved and whatnot. The quality improvement clinical audits that Miranda's developed are available in Dropbox or through Miranda, or we could forward it to you as well. So if you are interested in more detail, you can do that. But for the snapshot audit, it's about keeping it standardized and as minimum as we can get it, where we still have some service, where we're learning about the service that's delivered nationwide. So moving on to routine inquiry. Any other questions about child protection before we move on to intimate partner violence? Anything in the chat box, Kathy? Okay. So routine inquiry, the first question about assessment is, was the woman asked the 4 family violence guideline recommended routine inquiry questions about IPV occurring in the past 12 months, say? So most of you and most of your services will have some kind of routine inquiry stamp or box that's included in your records for each of the designated services where people can simply respond whether the questions were asked and if they were asked, if it was positive or negative. So this is talking about looking at the records for, in that particular, based on your system, where it is meant to be documented, whether the routine inquiry questions were asked. So a yes would be that it was documented, that the person was asked the questions. And that is, you don't need to have documentation that the 4 questions were asked. The idea is that your procedure identifies the questions that are asked to be asked. That's what you train to. And when they indicate that, yes, that is meant to indicate that they were asked the 4 questions that are standardized in your district. So it's documented that the person was asked the questions, would be yes. Now, sometimes there's times where a woman may disclose IPV without having asked all 4 questions initially. So you would say, well, is that really routine inquiry, or was that just something where the woman self-disclosed? But for the purposes of the snapshot, if a woman self-discloses, that is a yes for routine inquiry. And we assume that if someone discloses that the other routine inquiry questions actually are followed up and asked. So if someone says yes, it says, well, this is happening to me, then the staff person would probably go on to ask the questions, which talk about the different types of abuse, say coercion, fear, etc. So that's why if someone self-discloses, we capture that as a yes. And even if someone comes in brought to the ED, for example, by police after a domestic assault, we still say yes with the idea that it is a pathway to getting service. And that the routine inquiry question should still be there. So people could argue, well, that's not really routine inquiry, but we are trying to do a minimum data set of services that are delivered. And if that's the entry into VIP, whether it be through the police coming in the ED, the woman self-disclosing, or us asking the questions, all of those are entries into a service. Does that make sense?
Yep, that's good, Jane. Beverly had just asked, just before you said it, she said, is that the same if somebody's brought into ED by the police?
Yeah.
And then you answered that, so I said you were psychic.
Hey, we're channeling, Beverly. Thanks. Excellent. So the no's then are everything that is not that. So there's no documentation. There may be, in some districts, they encourage people to document why they didn't ask, if they didn't ask, like no privacy, partner with them. In terms of the service delivery, that may be important information for you in thinking about the environment and how you support talking about family violence. But in terms of nationwide, us delivering a service, when women enter a service, do they do they have family violence talked about? So we expect that they do. So there may be reasons why people didn't do it, but for the snapshot audit, I don't care. I don't care what the reason was. The bottom line was that somebody didn't get the service. So the idea of why they didn't get the service, that's for a local investigation. Hey, so if the proportion of women who are being assessed is low, that requires some learning from the system. What's going on here? Are people not trained? Have people don't feel supported? What are the barriers to being able to do this and do it well. So from the snapshot audit, though, anything else is a no. And then particularly in the child health, inpatient child health, you do have an opportunity to say during a child's admission, when you review that chart, it could be documented that there is no female caregiver ever, that's not involved with that case. And so you are able to tick that box. Well, we have looked at that in the past. It's quite a low number. So we actually, we don't take them out of the denominator. We leave them in the denominator, and it does introduce some error, but it's very small measurement error. But you do have the opportunity to elect to say no female caregiver. I think our rationale for that actually is that we don't want people, on my shift, the mother's not here, only the father's here. Well, that doesn't mean during that child's admission, there's not another opportunity, maybe when the mother does come, that someone does an assessment with the female caregiver, right? So we want to encourage people during the course of an admission that there is an opportunity to have a conversation around family violence with the female caregiver.
Just thinking, Jane, I mean,
Yeah.
once again, what about if you've got two men who are parenting a child?
Yep.
So
Well, you've raised the issue of a problem with our guidelines, eh?
yeah, that's right, because it's only females.
That's right. So very much that's a gap in our guidelines. So the snapshot audit is based on the guidelines. So you're that having a conversation around family violence with the two partners separately is a possibility. And in primary care, we would think that everyone would have an opportunity, creating a safe environment for people to talk about family violence. So to me, that's ideally what we want to do. We want to create a safe environment for people to talk about family violence and choose to perhaps disclose abuse or trauma that's occurred to them or is occurring to them. So good question, Kathy. So anything else about routine inquiry?
I'm just thinking with our sample, we will not have men. Our
Yeah,
criteria
that's right.
would be that women.
That's right.
Yeah.
Yep, because that's the guideline. So the eligibility criteria is female. I mean, it doesn't even, the guidelines don't talk about transgender. They don't talk about, the guidelines now are, they're getting dated quite quickly, eh?
Hmm.
And we're learning to do better. We're learning to do better about identity and difference and diversity. And so, yep.
In our emergency services, a lot of staff say they ask men and women.
Yeah.
And so in our other data that we keep, so, when you receive a disclosure and documentation, I note down men or women. So there's other places we hold that data, but not the snapshot.
Yeah. And the guidelines, to be fair to the guidelines, they do say that we should be assessing men if there's signs and symptoms.
Yeah.
So it doesn't, our guidelines do ask that, but we don't collect that in the snapshot. You would need much more than a sample of 25, I think, probably. Given the prevalence rate would be a bit lower. So you would need quite a large sample, but it doesn't mean that it's not important and not valuable. So those are all good issues. And I think you're right that more, just like some EDs that collect child protection checklists, on children up to maybe 14. So those things are all possible for different districts to make a decision about on what they want their responsiveness to be. But this is considered the minimum data set. So then was IPV disclosed and or identified, I'm saying. So no, the woman did not disclose, or maybe it said she was asked, but there's no documentation of what the response was. And a yes would be that she said yes to one or more of the questions, or again, that the case was identified by referral source. And once there has been a disclosure, the question then is, were appropriate referrals made? And so this is either a yes or a no, but on the yes, we have two options. So on the no would be there's no identification in the notes that referrals were discussed, or the notes indicate referrals, but don't indicate to whom or appear incomplete, or documentation that a referral was refused. And then when there was a referral made, we have an option to select either active or passive. And in the snapshot database, they use the term actually of on-site and off-site. But the meaning behind on-site is that for an active referral, it's that there's a direct referral to timely access for support by a family violence trained specialist who can provide danger assessment, safety planning, and access to community services. So that specialist service can be provided by police, social worker, a family violence advocate, someone from Women's Refuge. It could be a clinical specialist nurse who's done work in family violence. So it is someone who has had advanced training and being able to support people. It could be someone from the local Haora. It could be a range of things, but it's people who have received specialist advanced training and responding to family violence. And it could be on-site provided by health staff from the district, or it could be provided by others. So it could be that you have a contract with Women's Refuge, for example, that someone from Women's Refuge will respond. It could be someone internal, like a social worker. So every time that there's a positive disclosure, that a social worker is called. So what we used to say is that, our protocol is that we have social workers who have skills and helping support women who have experiences like yours. And I'm gonna, Mary is working today, and I'm gonna give her a ring, and she could just introduce herself to you, and the two of you can decide where to go from there. So it's about creating a warm referral, as opposed to here's a brochure. And a passive offsite would be here's a brochure. You may decide to call this number in the future, which is appropriate, but what we'd like to offer is an active, warm referral. And then that referral, there can be a determination of what the woman's needs are and she can direct, based on her needs, what referrals are useful to her, might be useful to her.
Jane, there's a couple of things. First of all, a slide back, I think. So if the woman discloses that she has experienced abuse, but it was 3 years ago, is that counted as a no or a yes?
Well, that's a very good question, Kathy. In Snapshot, it's a no.
Okay.
So what we're looking at is for responsiveness to the current IPV, which we consider the 12-month. I personally I find that very difficult because of trauma-informed care. So people who have experienced traumas, I think, for example, as a nurse, social worker, and others, an assessment, if we're doing an assessment of health and well-being, we should be doing a trauma assessment. And that would be for historical traumas and current traumas. And they can be a range, in many cases, they're asking the ACE questions, the adverse childhood event questions. So for me, as a health provider, ideally, we're doing a thorough assessment that includes a trauma history. But for the purpose of Snapshot, it is that a response to the questions that inquire about current abuse. Now, it doesn't mean that, someone who was had left a partner 3 years ago, but is still being stalked. That she probably still has fear and, so to me, that is a current abuse. So it's not related to whether she's still with the partner. It's whether she's still whether she's experiencing abuse in the past 12 months. It still is a blunt measure, isn't it?
Yeah, it
Yeah.
is. It's interesting, isn't it?
Yeah, and it doesn't mean that someone doesn't need services. Hey,
No, absolutely not.
Yeah.
I guess it's that thing of just because she's not with him and not experiencing any sort of physical abuse, unless we go into control and coercion, we really don't know whether she is
Yeah.
still experiencing anything.
Well, that should be captured in the routine inquiry questions. So that's a positive, if there's control and coercion, then that's a positive disclosure. So that's definitely a yes, Kathy.
True. Okay.
So go ahead.
Sorry, there's a question here from Diane Rees, who's Christchurch, Canterbury. Is there a document or a tool that you have that our staff can collect the data? I'm asking for the areas that are not automated and need to go through random patient files and paper collection. Short answer to that, Diane, yes, there is. And if you come next week to Monday or Wednesday, which you can hardly wait for, I'm going to show you what I use here at Auckland.
Great. Good question, Diane. Because a fair amount of services, Snapshot was created with the idea that people could enter the data as they have the record in front of them, they could enter it directly into the snapshot. But in some systems, it's just they prefer to do something different. For me, kind of having a data background, anytime you go from the record to paper and then enter the data separately, you introduce the potential for error. But I think the feasibility and who's doing the auditing and who's entering the data means that that's not always done. So that's absolutely fine. You have to work out a system that works for you. So that's okay. I think in some units, like community mental health, they may require that their staff do the audits. So there could be also in having champions. Ideally, in some of the services that you have, it's fabulous learning for the champions to actually conduct the snapshot audit, the random sample, and review those 25 records. So there's a lot of good reasons that people might be doing the review and just entering it on paper or in a Excel spreadsheet or something, rather than directly into the snapshot system. So we wouldn't want every champion to have a login for snapshot. I don't think we could do it, but I'm not sure that would be the best management of the data for the system. And as everybody knows, I haven't specifically said it, but we don't ask any other identifying information. So we don't collect NHIs, we don't get other identifying information. So the list that you may get from your IT department of your random sample, that will probably have identifying information on it. So that'll be your responsibility to manage that confidentiality. But what goes into Snapshot, none of that goes into Snapshot. And we do have we've had ethics approval from the Health Quality and Safety Ethics Committee, the Health and Disability, Ethics Committee. And we renew that every year. So we do have the referral number, I think, on the Snapshot information. So when you engage with IT department and whatnot, you can clarify that no identifiable information is coming out and that is being released, and it is a secure password only database that we have the data centrally at AUT on our AUT servers. So again, learning as we go forward in all of our data that we collect through research, looking at Māori data sovereignty. And we've had some conversations with Sarah about that. And that is one of our practices that has always been that ethnicity is analyzed by our Māori evaluators. But there's probably more we could do as well as we challenge ourselves going forward in time. So this is what this is in child health inpatient, just a screenshot of what it looks like. So here's the ethnicity, and here we do ask for the child's age. And this is whether the female caregiver was the routine inquiry. So here's the yes, no, or no female caregiver. And here's whether IPV was disclosed or not. And then here's the referral, yes, on-site, off-site, no. So if it's an active referral, it is that notion of the person is getting that access at that point in time during their visit. There's probably some case where it would be, well, I don't know. I don't want to create, someone could come up with a scenario. I haven't thought about this lately, but where it would be off-site, but it would still be considered an active referral, not a passive referral. So what is the meaning behind what an active referral is? That someone is disclosed and they have access to someone who can give them, who has experience and skills in supporting people in whānau who have been impacted by family violence. So that's what the data entry looks like, and Kathy will go over a lot more of this. So essentially, that's it for today's session. The next session, Kathy will be talking about entering the data. It is offered twice because we know some people have MDT meetings on Wednesdays and etc. So it will be offered twice. And in that session, she'll talk about just a bit more about the Snapshot audit website and entering the data and answering your curly questions. So come prepared with any curly questions for the next session. And hey, Patai, anything about any of the slides or about the measurement of the variables that we've talked about today? Kathy, have I addressed everything in the chat today?
Yes, there's nothing else in the chat. That was great.
I'll go ahead and close with a karakia whakamutanga then. Kia whakaria te tapu, kia wātea ai te ara, kia turuki whakataha ai, kia turuki whakataha ai, homie, huye, taikie. Have a good day, everybody, and feel free to email or call us. We're here for you. And we'll see you, Kathy and I, at session 4, maybe. Cheers.